Good morning. Oh my God, it's been a long day. Most of the day I spent laying down trying to just, regroup, get myself together. As some of you know, I travel a lot. And the last time I traveled, my feet was so swollen, crazy. And it happened actually just a couple of days before I left. And then imagine me getting on a train going 31 hours to New Orleans, Louisiana for the American Counseling Association Conference and Expo 2024. A lot of travel. So while I was there the whole time, my feet were just, and not only that, for some of you, you know that I've undergone major surgery and not too long ago come out of a wheelchair. But this is progress because I'm walking, still going through some things, but I'm better than I was. So here's the thing, this is code psychology. Code psychology. And this is also Elise. So, what is a code? You know, sometimes when we're in, a crisis or an emergency state, you can hear a police officer or, some kind of medical provider or whatever. They'll call a code red or they'll call a code blue, meaning this is a critical moment, code red. And code blue also, somebody is dying or has died or there's all kinds of codes. When we talk about code psychology, in this instance, it's about the code that a group of people follow just because they have a commonality amongst them. Now, there's really nothing wrong with commonality code. But then again, there can be some very huge gray areas. Because if there's a code and there's commonality amongst people with it, it may have to depend upon what is truthful and what is not. So if each individual has an idea about the truth about something, but because there's a commonality bonding with them with regard to, you know, maybe the circumstance or the situation, the onus on them is actually to tell the truth. But you know what they would do sometimes? Because there's this commonality amongst them. Let's give it a little bit more substance. A group of doctors, a group of firemen, a group of policemen, a group of medical first responders, a group of teachers, a group of motorcycle club attendees or riders, a group of fishermen, a group of librarians, a group of sanitary workers or sanitation workers. They do the sanitary work. Sanitation workers, a group of conductors. So, a group of police. Does it mean that just because these people carry the same title in their respective categories, that they should turn a blind eye to truth? So it's almost like saying, if they engage in that manner, that just because we are of the same, we do the same, we think the same, we act the same, So it's almost like see no evil, hear no evil, speak no evil, while somebody else or the targeted subject is not a part of the code commonality, but they are actually receiving the brunt of what a number of people who belong to that code commonality actually feel about them, regardless to whether or not what they have done or what they have exhibited, what they have said, what they're connected to, or what has happened is right or wrong. So what if life and death? What if life and death? What if life and death is in the hands of these people? And they know, actually, that the person could live or should really live. But maybe because this person represents, I'm talking about the targeted subject, represents a certain, type of people. You could break it down to race, break it down to ethnicity, or perhaps a certain class in terms of wealth and money, or in terms of just exhibited behavior. Maybe, when it comes to exhibited behavior, it is really that the person advocates for themselves. And maybe they're in all three classes in the minds of those who are with that commonality code. So you could be black, according to some, African American ethnicity. You could be on welfare, and perhaps not. Or maybe you have a partial something, but in their minds, they call it welfare recipient, regardless. And then on the other side of it, you advocate for yourself for what is right. And across the board, regardless to what anybody thinks, you have a right to be serviced. So let's add something else with that. They look at your history and make a decision about giving you service based on whether or not you filled your last prescription. But what they don't understand is that when you came to them first or second time, you let them know that there was a problem with, your body in terms of swelling. And that maybe you were thinking that it could be the present medications that you're taking. You let all this be known because that's what you do. You talk to your doctor, you let them know the kinds of symptoms that you're having, and they give you their spiel or their take on things because you're trusting them, quote unquote, with your life in their hands. So what would make you not trust them? So all of this goes on. And you take your blood work, and your blood work may come back okay, and as well as what they say to you. But then here it is that you gave them the information about this medication, and you even went so far as to tell them that you got in touch with the pharmacy. And the pharmacy, actually, what they did was give a completely new batch of medication somewhere along the line because of the symptoms that were being, shown or exhibited, which might have mimicked a different or another type of medication that in prior years gave you trouble. So let's give you something definite. So if you were on a pill called perhaps lisinopril, lisinopril makes a lot of people cough and have a frog in the throat, like a constant cough. Could also make you have sweats, could also make your legs swell, just different things. And, you've experienced some things from taking that pill a while ago. So you stopped taking that pill because you were given something else because that one did not properly work. So now here you are with the pill after a few years that has been working, and now you're having some similar symptoms, and you're raising the question, well, like, is this really lisinopril or is it losartan? Or is it because it's making me feel like this or feel like that? Not only that, while you were, being serviced inpatient, they kept prescribing lisinopril, but you were definitely and clearly on amlodipine and losartan. But the nurse would come to you and go, well, here's your lisinopril. And you're like, no, I'm not on lisinopril. But your current doctor, you have not privied her to your in-house or your inpatient experience in terms of, the distribution of medication. But at any rate, your pharmacist says, you know what, I'm going to give you a whole new batch. And it's kind of sort of midstream. So you have, maybe not even mid, almost going into mid. So now you have these old pills, right? You hold on, and he's like, hold on to them. And he gives you a brand new batch from totally different manufacturers. So why would that be? Because perhaps there really was a problem. Maybe he could not come out and say it, but obviously he did what he believed was the right thing. So we got that new batch of medication. So for some physicians, it can look like in the record you didn't keep up with filling your medication timely. But you already had enough to cover you beyond the date because kind of midstream, you got a whole new batch of 90 days. So there's a gap in between. So it's not like you didn't take them. No, you took the medication. The old ones still exist, but the new ones covered. And whether or not it was put in the system in that manner, it would not be seen by your physician in that way. But your doctor, but your pharmacist did his due diligence in trying to make sure that it wasn't a manufacturer problem. And obviously, if it was changed, then something. But you're relaying messages to your doctor that this is what happened. So if the doctor sees in the system that you did not ask to refill your medication, what would they think? That you were irresponsible? Yeah, would they think that you were irresponsible? And so then, well, why should I agree to approve her medications just because now she wants to refill them and she hasn't had them in 3 months or 2 months? Why would I? But rather than be real about it and just come out and say that this is a situation, they put something in your chart like medications denied. What do you mean medications denied? So you're traveling like I was, and I'm calling beforehand to get my medications. Beforehand. But I go through hell in trying to get them. And they don't come through until days a couple of days or a few days after, but I don't know that. And you see, that's the whole point, the delay in service. If I've asked already from the beginning and the pharmacist or pharmacy has also asked. So here's two things. If it's the same institution, medical institution, whether or not it's in New York City, the location, or in Hudson Valley, the system of communication, the system of documentation, the system of notation is the same. But let's break it down a little more. The system is the same as it pertains to every person who has been given under that commonality of code, doctor, the opportunity or access, or to have access to the medical record or the portal. So when a decision is made like that, where actually is the doctor coming from with that decision? So you mean to tell me that a patient could be just waiting and the doctor deny medications that they've been on for a number of years, whether or not it was amlodipine, losartan, methodopa, atenolol, lisinopril. The list can go on and on. Beta blockers, channel blockers. It could be a bunch of things, whatever it is. So you would deny it. And how would the patient know? She's waiting. He's waiting. But because a doctor looks at something, the doctor makes a decision. So are they also making a decision to say that it's time for you to die? Because let's look at the reverse. If your medications have been denied and it's based on a personal opinion, and this is perhaps a first time, but let's forget about even a first time. What would make them make this decision if these medications sustain your life? What would make them make this kind of decision if these are the things that help you to function on a daily basis? But they're always telling you, take your medication and do this and do that, but you do it. And it's not that they always tell you that, but just in rote communication, they want you to be accountable. But you are accountable. So now they decide to just end your life, but you don't see it until you maybe go in your portal and you see medication denied. And what is it? Oh, well. So, code commonality on a personal tip and then on a corporate tip. I could give you so many examples. So here's the other thing. Upon coming back from me, I actually did not have medication the whole time I was there. And my feet and my legs and everything was just so swollen. But yet, the pharmacy sent out, they asked a few times. And then I had to call out to the PCP. It was so much drama. And then I spoke to someone already, and then they were in the New York office. They were like, well, I'm going to try to do the best I can to get this to happen. It shouldn't have been a problem because we are the same medical institution and blah, blah, blah. And I put word out to your PCP and da, da, da. You don't hear anything. You don't hear anything. And then the pharmacy is saying, well, we could only give to or call out to the last person that did the prescription for you. So this is one in New York, and the one in Hudson Valley has never done it before. But really, should it have been that much drama? Like, really? We change doctors according to the rotations. And sometimes we change doctors because maybe one might not be a right fit. But if there's that commonality code, why is that? Why is it that personal opinion plays a part across the board in how you are treated? And because they have access to your medical records and charts, you don't actually feel or you don't actually see what's going on in terms of the commonality of code that they are all expressing just because of maybe one or two doctors, observation or personal opinion about the communique between you and them. That's one example. Another example would be, okay, so maybe they have already pegged you as a Black, African American, non-Hispanic. But maybe the truth is you're not that. But you've also done your homework. You know your history. Look at this. You know your history. You know where your granddad is from. You know bits and pieces about your grandma. And you know what the blood types are, and you know these different things. So you're not identifying as what you might have used to in the past, or they were already knowledgeable about what you were and who you were. But you see, long time ago, there was a thing to squash the truth about people's heritage. And they would look at the skin and classify you, maybe based on where you lived, and what your work was. And there's lots of things that you could think about or to think about with regard to how people are classified. And then when you find out more and more about your heritage and more about, just bloodline stuff, all of that inclusive. And and then you go back in the pictures and you're like, oh my God, people don't want to apply truth to what they have already, quote unquote, established. And it's sad that even with the code of commonality, people don't want you to say what you really are. They don't want you to know what you really are. And then when they look at you in the face and you look at them, they see themselves and you see you. And then it's, oh my God. So, are these real scenarios? Yes, absolutely real scenarios. And then let me put another little piece on there. So what if it is that you are looked upon, regardless to them knowing the truth about, the blood type, the hereditary, the whole thing, right? But you're logged as this. And what if it is that you are receiving Medicaid? Is it fair to say that because someone is receiving Medicaid that they are a welfare recipient? It doesn't mean that because you have Medicaid that you use food stamps. It doesn't mean that you get a stipend every month. Not necessarily. It could mean that you work. It could mean that you still have your own business. And according to the code of commonality, look, I don't care We work every day. And why should she or why should he? But they don't even understand the dynamics of what goes on or can go on with a person. And they don't even understand how it is, or if it is something work related that has caused several things to happen in your life. And if it is, and if it was, well, then certain things you are and may be entitled to. Because here's the thing. Nowadays, I've been through it myself, testifying at the state Senate hearings in 2019 about the Affordable Health Act. And I shared my stories of the process that I went through, and some of the things that I did not receive with workers' comp, how I was treated. So it didn't mean that I never worked a job and I'm just living the life of Riley, everything free to me and I don't do anything. Well, let's stop right here for a moment and segue. City worker. Not only that, entrepreneur. Not only that, retired city worker. Not only that, entitled to much. But because of a commonality of code with the medical profession, some people within that code have their own perceptions or their own observations and judgments about where I am and what I receive. But here's the thing. If you are my provider or a provider, none of that should matter. What's most important is that you get paid, not how it is I came to be with this or how it is I came to have this. And then on top of that, I'm letting you know the truth that I have other insurance. So who pays for it? I pay for it. But that's none of their business. So here's the thing. With the commonality of code, is it just a personal jealousy? Is it just a personal, well, why should I give her this kind of treatment? And she doesn't work. And she doesn't, or why should I give her off? I need to be saying to her that we can't medically qualify her for short-term disability. Well, what would be the reason? Oh my God, I just came out of a wheelchair. I'm going through some situations walking. One provider is saying to me that I'm not disabled. And then according to his judgment, but I'm going through physical therapy. I'm also having some other symptoms. I'm treated for this. I'm being treated for that. Now they're saying my medications are denied, but I'm having these kind of symptoms. I'm letting the doctor know this. I'm telling her what it is that I kind of think, but I'm not really sure because I'm not a doctor, but I know my past history. My pharmacist, I'm letting him know what's going on, and he's doing his little research and due diligence and feels like things should be changed, so he changes them. But that commonality of code across the board. So who's thinking independently? Who's thinking survival? Or who's thinking it's time for her to go? Boop. Well, how do we do this? Well, based on the commonality of code, we just deny. We just stop, block, and shut down. So let me give you one more. I'm trying to get to the doctor because now I'm having some other things that are happening like crazy. And they're showing up like big time everywhere. I mean, my first time with this. And I'm concerned, but I'm not filled with anxiety or crazy over because I have peace in my heart and peace of mind that whatever came, it will go the same way. But I could be and have a right to be really concerned. So I'm trying to find my way to the provider. The last time that I went, I paid $35 each way in a cab, $70 one day in a cab plus my train fare. So that was a bit much. And normally I do not use the cab benefit that I have because I pay for everything. I pay for everything. And I'm finding out now through the transportation that even if I take the train, there's a bus that goes directly from one train station all the way to the provider's location. I'm like, this is great. And I'm gearing up for this. And then I call. Something says, well, call. And I call, and the lady says to me, well, there is that bus and there is another route, but we're having a lot of difficulty with these routes these days, and that the bus starts at 5:30 in the morning and the last one is at 6:30. But my appointment is 11 o'clock, or my appointment is 3 o'clock. Are you kidding me? So I can get there if I was to get there maybe at 8, but then I still have 3 hours to wait for my appointment, and then there's no sure way to get back to the train. Are you kidding me? And then one says, well, go to this stop, take the 14, then take the 10. But the 10, it kind of comes at 11. But then the 14, you still can't get, oh, craziness. This is stuff that's beyond my control. And I'm trying to make it there because I understand the urgency of what's going on with me, but I might not be crazed about it like, oh, no. But it doesn't mean that I'm not concerned. It doesn't mean that it's not emergent for me. So I'm talking to the nurse practitioner and she's telling me, well, I really believe, that you should be seen, blah, blah, blah. I'm like, well, could we do a virtual, in time still today? And they set it up for me. Everything is set up for me like at 1:30, and I'm like, great. Got this virtual and blah, blah, blah. We can keep it moving. And I already had sent in, get this, pictures. Taking pictures of my legs, my feet, and, body parts just to, give them a heads up on what it is that I was experiencing. So did they not see that? Did the provider not see? No, she saw it. So the virtual was set up for 1:30. And it was set up in the early morning. So get this. I also put it in the chart, upon sending the pictures, what was going on transportation wise with the phone number. Because I don't have time for games. I don't have time for play. I'm concerned just as much as they should be concerned. So here's the thing. I get a phone call at around 11 in the morning or 11:30 in the morning from the practitioner telling me that she doesn't think a virtual will do because she needs to see me before she can, refer me for blood work. Okay, so if we did a visual and I was to put the phone to look at what I have, and I can understand that maybe to touch or to feel would be something better, perhaps. But in this situation, which could be of crisis mode or crisis matter, right? Seeing me and talking is just like if I was there present. And given the circumstances of not being able to get there like I would have wanted to, what would have been the best? So the nurse says to me because the doctor says the virtual is not going to do. She can't refer for blood work because the virtual won't do. This is at 11:30 or 11 o'clock in the morning, but the virtual was already set up for 1:30 in the afternoon. Please explain. Please explain. So everybody's on board knowing it's approved. But then again, please explain. A personal call to me to tell me that it won't do. Then the nurse is talking to me on the phone because I'm concerned, like I need the blood work, like I need to do what needs to be done. Well, I'm concerned that you go and be seen by someone today. So I'm calling up my insurance company saying to them, is there any way that you can make it available to me to take me all the way to the provider's location? And they're saying, yes, we can, but here's the thing, these two forms need to be filled out, blah, blah, blah. Try to get all of that done and out the way. It's an emergency, it's early, but the appointment can be changed to a later time and all of this. Well, then the nurse is saying, okay, go to an urgent care. Now think of this code, commonality of code. So we go to an urgent care. There's some drama that was going on in between there too, but we make it to an urgent care. So now I'm seen by a doctor, but it's actually a nurse practitioner. Beautiful place. And the doctor stands over there, and I'm sitting here. And then I'm saying to him what is going on, and he's talking. And I'm actually thinking, maybe he'll draw blood or something because physically you can see. And I said to him, well, don't you want to take a look at what's going on? And then he finally comes over and he says, okay, just lift your pants leg and lift it up. And because I have these, very, very, large patches of red and, discolorated lumps and bumps and on my feet and just that came out of the blue. And he's explaining to me what it could be with all of what I've gone through. And I'm like, okay, thank you. And he says, well, there's nothing else for me to do but now for you to go back to your PCP or go to your PCP and like follow up with the rest. And I'm like, okay. So how does this all play out when I have done exactly what I was told to do? And here I am now, 3 days later or 4 days later, and still no blood work. So I go ahead and call the insurance company to see if these forms have been done. Now, I've spoken to the nurse practitioner. Well, the sooner you get this in, the better. And I have made like 2 or 3 appointments. And then I'm also calling the cab driver because an appointment time for the cab ride had literally went in for the same day that I was going to the urgent care to be seen. And the cab driver was actually almost to Beacon. And I said to him, because they gave me your number and said, that you would be picking me up at 2 o'clock or something, or other, 1:30, 2 o'clock. And he goes, but they didn't ever tell me. They didn't call me and tell me that it was approved. I said, well, you were going to take me to, the urgent care. But he said, but I'm actually on my way. I'm past Beacon. I'm going to blah, blah, blah. I said, what? I said, if that was the case, I could have gone to the location where my PC. He said, if they would have told me, I could have taken you. But he said, they're kind of messing up lately. And I'm sorry, but I can't even turn back and pick you up to take you where you are supposed to be going now. So I call the cab service back or the medical provider back for transportation. Like, I can't get this cab because he didn't get the notification. And then they go like, okay, we're going to send someone else. So I have to wait another hour. I'm in the street already. So I sit there at the bus stop. I came out from the front of the building and sat at the bus stop because there's no seating outside. And I have to wait an entire hour for another cab just to take me to an urgent care. But with all of that said, I get seen. And the gist of it, or the crux of the matter, I was seen by someone. So now I'm still trying to get to the PCP to get a referral for blood work. And then I find out that the form that was needed was uploaded at like 4:09 in the afternoon. And it now takes 24 to 48 hours for approval. So how did it not get approved? And here I am still without what I need. So am I running the risk of developing other symptoms? Is it left up to me, which normally is, to continue to care for myself in the best ways that I can, regardless of whether I saw a PCP or a nurse practitioner or not, someone physically or virtual? So, what would it be to stop a provider from referring me for blood work? Would you not have taken the word of the urgent care person who saw me and could have actually conferred? I'm shaking my head, but I was told to be seen. And okay, so I was, rightly so. So here I am now, looking at an email and looking at a portal that says, not even a portal, an email came through that there's an earlier appointment for me. But I canceled the appointments because the cab wasn't available for me. And I started to check around at the notice of the practitioner, the PCP. Well, maybe this is just too far for you, and you should check someplace else that's more closer. We just don't want you to travel so far. And I thought about that. I really thought about that, and I said, you know what? It all sounds like they really care, but to me, the underlying tone and the fact that from out of the same office, a suggestion was made by the nurse, another nurse, to be seen, means that there's no connectivity with regard to onset service and then service after, which would ultimately get me to the place of having blood work done to definitively give me an answer, a provided answer as to what could be going on with my health. And somebody wants to say they really care. Well, maybe you should not travel so far. We don't want you. And let me give you one more. I was going through something and traveling, and was said to me, can you come in at 8 o'clock in the morning? But I was not given the definitive address to where to be. Now, this doctor frequents both places. So I take 3 trains early in the morning to get to one location because I'm thinking that it is this location. 8 o'clock in the morning, I'm there. But I'm leaving to go to Florida that day. And my train is coming at 11:10 in the morning. Back in Dutchess County, but way up. So I'm standing there and the door is not even open. And I'm like, oh my God. And then somebody comes and opens the door and then they're like, oh, well, your PCP she's not here today. She's all the way over there. And I'm like, what? Are you kidding me? So it's not necessarily that I did anything wrong. It was an honest mistake, perhaps, or that's looking at it that it's on me, or perhaps it was a mistake on the other side because I had just, come to be in this practitioner's care. So things happen. And you know what happened? I ended up talking to her on the phone, just like as if it was a virtual, but was experiencing some things. and I travel. And whether or not she believed that I was going someplace or not should have had nothing to do with it. And I literally said, I can't go through the games like this. And I'm not suggesting that you're playing a game, but to me, it's like a game in the sense of I took 3 trains, miss, to get all the way here. And then to be told, like, well, can you come tomorrow at 8 o'clock in the morning? No, I can't. It was enough for me to make it by 8 o'clock that day and then having to go all the way back to catch a train at 11:10. And I didn't have my suitcases with me. And I'm walking with a cane. I'm in therapy. I'm like talking about stressful. I was like, I can't. I can't put up with this like this. This is not good. Not laying blame on anyone, but if I was told, even from the person who made the appointment with me, you see, sometimes it just goes through a general board. You know what I'm saying? Depending upon the number or your transfer here or transfer there. And if the definitive information is not given, then there could be a mix up and a mishap. And okay, so there was. And now I'm thinking about the undertone as though maybe I'm perhaps not responsible. And I didn't want to take it that way, but now I'm looking to where we are now. And I'm still at this point without blood work. Commonality of code. Commonality of code. And I'm looking around for someone else and I'm finding that, I go to therapy over here, so I can go over here perhaps and find somebody. Well, they're not taking anybody over here. Or perhaps maybe somewhere else. And then I'm given a suggestion to go back to the first place that I met the provider. And she has someone there that, but in my heart of hearts, I feel like, no, no. So, what are we to do? What are we to do? She makes another suggestion. Oh, well, your knee pain, blah, blah, blah. Okay, so I get a call from someone. And I do have my appointment. So is it that now this doctor is going to provide me with a referral for blood work? Knee pain has to do with physical therapy. But when you have knots developing with discoloration, epithelial wise, under the skin, that could be seen, black and blue, blue, black, or peeling skin or darkness or all of that, is that actually orthopedic? Or is there something else that could be going on? Could it be exacerbated over time because of the fact that it's not addressed in a manner, conducive for best health or best, recovery, best healing? So then where does the onus lie? Code psychology. Is it the individual's take on things about you and then spread abroad so that the treatment may be the same because doctor is at the end of the name on some of these people? And if that is the case, then why would anyone want to put their life in your hands or in their hands? And here it is. I have been going through, oh my God. And I was asking for, just to take, I needed just a short break to kind of get, oh my God, just, and then trying to get medically approved. But each one is coming back with some craziness. And one doctor had the nerve to put into the chart that my only concern was to take time off and not really my health. Another doctor wrote something up that would have sufficed, but the way that he wrote it, it wasn't correct. And I don't play games when it comes to that. I don't, if that was the case, if I was this charlatan or just wanted, I could have just said, well, I could submit this and get it. I did it. And I really do believe that they were looking at me, those who are part of the commonality of code, to see if I was just going to accept it and put it in. Well, I didn't. And I also let the insurance company know that this is not correct. But there were ways that I could have been medically approved and should have been. And not only that, well, who pays for everything? Pray tell. Do they pay for it? Oh, well, maybe your employer. I am the employer. What if that's the scenario? I am the employer. Do I have a right? I was also the worker, twice removed, entitled to benefits, still fighting. And if I had not looked out for myself, I wouldn't even be on my feet today. I would have been without a home, without medical care, just without. Who's to say that I am receiving the gamut that falls under my insurance? I'm not. But because of the code of commonality, and this is not just happening with me, I'm sure it's happening with other people. Personal opinion sometimes rises to the occasion when making decisions about a patient, or can rise to the occasion, when it comes to making a decision about the care and concern of a patient. I would rather you just tell me, I don't want to see you. Or I think that, but then again, I was told, well, we don't want you to travel so far and you can go. And the thing is, when I first met this one, I really liked her. And I loved her notes. And I compared her notes to what I've seen. And I was like, wow, this is so beautiful. And you know what happens when you find somebody that you think is really good? You want to stay with them. But then once you start to look at things sometimes, and you should analyze, you should. Because just because they seemingly are good, and probably are, thinking about undertone and thinking about causation, thinking about setup, thinking about alternatives, thinking about health, sometimes you can come to the conclusion that, you know what sounds good and what looks good and what seemingly is good may not be good anymore. I may not be medical in the sense of where they are, but then again, I am medical. But they wouldn't know that, because maybe I was pegged. Maybe I was pegged as this: African American, Black. Maybe I was pegged as welfare recipient, not. Maybe I was pegged as a business owner wannabe. Maybe I was pegged as a charlatan. Oh, she has these insurances? What else do you know? What else don't you know? Why does any of that matter when it comes to wealth-wise health? Why does any of that matter? And been trying to take some time, and things just keep adding up. And you know what? The thing that so amazes me is, even if there was a gripe with another physician And here we go. Commonality of code. Why would you hold back just because another doctor was singled out? So then what that means is that you laid down your profession and you're fighting for the rights of that doctor, whether or not he was right or wrong. And he could have been so wrong. You don't have all the pieces, but because he has MD on the back of his name, what he says is gospel. It's the word. And it's not necessarily so all the time. You could have even been, for you commonality of code folks, related to, you know, might have been a relative. But does it still make it right? So it's like a matter of ethics again. Then why are you seeing patients? Why are you? Why are you doing this thing if you can't have an individual observation, judgment, call in a matter? But if one of your own, quote unquote, is saying this or that, you just jump on board with it and everything is shut down. Everything is stopped, blocked, and shut down because of the targeted subject or the patient involved. Every doctor is not right. Every situation does not, particularly mean that the patient is wrong. But then you want people to advocate. You want people to speak up. But then you know what also happens with those who are doctors? Immediately they already have a judgment. A face value judgment. Face value judgment. Don't know nothing. Face value judgment. And maybe you had some times before where you went through. And even if somebody wrote some stuff in your chart, you don't know all about it. You don't know everything, you know? And it says this or that. They just go with what they see. But then when they meet you face to face and you're talking to them, it's the opposite of what somebody wrote. They won't even consider that. They don't even know that you could be a scholar. And because you've gone through some things, maybe your, exhibit or your expressions might have been different at one point because of what you've gone through. And the sad thing about it is that they are so wrong. Could be so wrong. But if science says, medical profession says, we are here to heal. We are here to make well and to help people to function at as best possibilities that they can, or as close to 100% functionality as they can. Wouldn't you take in consideration that seasons change, times change, things change, progress can be made? Or is it that you just counted them out from the moment that you saw them because you already have a set of variables that you've applied to them because of this, not even knowing really what was behind not just this, but this, or even experience, or even environment. Well, 50% of Black people, well, 80% of Hispanic people. Is that what you're going on? Or is it that you think that you are so professional that the next person that comes to you with their set of experiences and these different things, because they look a certain way, they just can't be a professional like you? Maybe in another area, but they just can't be. Even if it was another area, there's no way. There's no way that they could be honored by the teaching diagnostic professions at Columbia. Or it's just not her. There's no way that they could be medical. It's just not him. There's no way that they could be pathology. Just no way. There's no way that they could be a lab and radiology buyer. procurement specialists, contract specialists. There's no way that they could have done this for the city of New York. It's no way that they know about Inkstar, Fisher Scientific, Curtin Matheson, Immunocore, Becton Dickinson, Technicon. There's no way that they know these things. It's no way that they know chemicals. It's no way that they know nuclear medicine. It's no way that they could buy med surge. No way that they could buy for the sanitation department, police department, the mental health department, the Department of, what is it? Department of Health. There's no way. It's impossible. Well, it would be impossible if there exists that commonality of code that already stigmatizes based on a set of variables that have been set by a group of people above and beyond. What it is that they see before them. And when I say that, it sounds weird, right? Above and beyond what they see before them. So in other words, if they saw above and beyond in truth, they would be considering that, this is my patient. I don't know everything, but I treat them as though they are human. They have an issue. They've come to me for a service, and I must provide that service according to the code that I've taken, an ethic, the ethical code, and the oath that I've taken. And even my personal opinion, I cannot let stand in the way of the people that I serve. And I can't let somebody else's opinion stand in the way, because then that would mean that I'm not true to the oath that I took, and that I'm standing for the doctors and not for the common cause of good that would promote best health and promote sustainability. So then maybe I should just hang up my stethoscope. And maybe I should just take up a grassroots cause for my own kind, which might work better, because at least no one is putting their life in my hands, and I'm not there at the place where I would just shut them down, stop, block, and shut down, making a decision to end their life just because of the code of commonality, or the commonality code. So for me, moving forward, I'm looking for the new. But even in the midst of looking for the new and knowing that there's some things that should have been done and could have been done regardless, because things were already put in place, I have to take care of myself. Let's just continue to take care of myself. And any given time, somebody wanted to know more, they could, if they would ask. But really, it's none of their business. It's none of their business. Whether or not I'm a business owner or not, whether or not they really think that I have what it takes to run one, whether or not they think that I am African American or Indian heritage, and whatever, to have skills or not. Whether or not they think I'm a psych patient or I went through some things, things happen. But if you're in the mode of healing, wholeness, and wellness, why would you allow those things to stop you from providing? Unless you have a fear. And what would be the reason for your fear? Because we advocate for ourselves, because we say, this I can't tolerate. Are you afraid that a so-called quote unquote black African American is able to communicate effectively with you, but you don't want to receive that and you want to call it anger or call it, because that's what people do, Not even angry, you're not even frustrated. You're just saying, look, I've traveled and I've come here and this is not acceptable. Is it that I didn't use a slang word that threw you off? Or is it that you thought that I was a crazed person trying to be more eloquent with my speech, but you couldn't accept that? Or was it that you preferred to hear Ebonics? And that would equate more to what you call me. Commonality Code. Well, I'm more. And many of us are more than what you see. And one last point with that. I was in the hospital as a patient, and there was a patient next to me. And it really bothered me how this therapist was dealing with this patient. And she kept calling the patient's name and asking her, did she see a banana? Do you see the banana? Miss Dr. So-and-so. Dr. So, do you see the banana? Do you see the color? Touch the banana. Literally, she was doing that. And I was saying to myself, well, what kind of therapy is she providing for this patient? And the patient happened to be a doctor. So you mean to tell me that all of this doctor's acclaim, accolades, and schooling and knowledge and work, efforts and, just developments, establishments, and grants and all these different things and service to the public just went underneath the rug, and she was broken down to simply being treated like an animal, like a monkey in a medical facility because it was based on what she looked like. But they were calling her doctor, and the woman was screaming out loud. Why was she screaming? Dr. So-and-so, do you see the banana? Can you tell me what the color of the banana is? Can you see the banana? What was that all about? Was it physical therapy? Was it occupational therapy? Why was it so broad and colorful and loud across the board? Or was there a statement being made? She couldn't speak for herself. It didn't take away from who she was. And a lot of times we go through things in life where we might not be able to express ourselves the way that you might want us to, or that maybe would be satisfactory to you. And it's not so much sometimes that it doesn't come out right. It's just that you're blown away by what we say and what we do, that you want to call it something else. You have a choice. Either you can hang up your stethoscope, take up another cause, or you can be the doctor that they called you to be and take your judgment and throw it in the garbage, your personal judgment, and do what you're supposed to do. Do I have a right to say it? Yeah, I do. And I have a right to also choose. And I made a decision to be on my way. because my health is more important to me than perhaps the stress of trying to get to be and see you. Commonality of code. If it's a doctor saying something, you would be more on board with that for many of you than you would be in trying to establish or maintain the health of one of your patients. So this is at least something to think about, right? Signing out.